Hello, and welcome to today's webinar, Top 3 Productivity Tools for Radiologists, Real-World Insights on Efficiency, Speed, and Collaboration, in partnership with AGFA HealthCare and the University of Michigan Sparrow. My name is Brian Casey. I'm Managing Editor of the Imaging Wire. Got a great program for you. Thanks, everybody, for joining us today. It's really great to see everybody coming in. We're going to start with a panel discussion in the first half of the hour. Then we'll open it up for questions in the second half. You can ask a question at any time using the Q&A button at the bottom of your screen. And when we get to the audience participation part of the program, we'll be getting to those questions. So I'd like to introduce our panelists right now. Our webinar speakers are Jasmine Holloway. She is Clinical Applications Senior Analyst at the University of Michigan Health Regional Network. Tammy Skoke, Regional Team Lead, Clinical Applications at the University of Michigan Health Regional Network. Kyle Solini, Director of Enterprise Imaging Radiology at AGFA HealthCare, and Dr. Osa Olomu, Chair of the Department of Radiology at University of Michigan Health Sparrow. Everybody, thanks for being with us today.
Thank you for having me.
Ryan.
Thank you.
Thanks for having us, Brian.
You bet. So let's start with introductions. Jasmine, can you go first?
Sure. My name is Jasmine Holloway. I have worked at Sparrow for over 20 years. I've worked in the imaging service line. I concentrate on radiology and cardiology and support both our EMR, which is Epic, and our PAC system, which is AGFA.
All right, very good. Tammy, can you introduce yourself?
Yes, thank you. My name is Tammy Skoke. I'm the regional team lead for this team. I have been with Legacy Sparrow for 34 years in a variety of roles, both clinical as a radiological technologist and in the HITS as an analyst and then later as a leader. We support multiple areas, including imaging, but for this conversation, primarily Epic, Radiant, and AGFA PACS. Thank you.
All right, very good. Dr. Olomu, how about you?
I'm Dr. Osa Olomu. I'm the Chair of Radiology at the University of Michigan Health Sparrow. I've been here since 2018. I specialize in body imaging and breast imaging. I'm kind of did a full gamut of radiology. Our practice is around 20 radiologists, and thank you guys for having me here.
You bet. All right, Kyle, how about you?
Thanks for having me, Brian. Kyle Solini, the Director of Enterprise Imaging Radiology, primarily focused on our product strategy, commercialization strategies, go-to-market activities in North America, working with customers like UM Sparrow on how we are solving provider and radiology needs.
Very good. Well, let's get started. So I think we all know that radiology is facing so many challenges right now, both radiology group practices and departments and imaging centers. Dr. Olomu, can you talk about some of the challenges that you're seeing there in your practice?
Sure, yes. In our practice of radiology, the one thing is the increasing in imaging volume. So every year, we kind of expect the imaging to increase by around 5%. Now, that is typically the case. However, sometimes a hospital system may take over a smaller hospital system, which will definitely increase the imaging by quite a bit more. Another factor that we have to deal with is with our staffing. So every year, we do see some radiologists go part-time or retire. So it's very important to continue to recruit new radiologists. However, it's becoming more difficult for some practices based on their location because some, depending on the site of the hospital, there might be less available candidates to move on site. So one option is to hire more remote radiologists, which is becoming more common these days. Another factor is having a very efficient PACS, which can be, speedy and good, either on-site or remote, making sure we work with IT to make sure that's all taken care of and fully functional at all times, because even when there's an hour of interruption, that could be pretty impactful to patient care. So there's a couple of things that we have to kind of constantly work through to make sure that we have a very efficient and productive practice.
Very good. Tammy, what sort of challenges are you seeing on your end?
So from a HITS perspective, it's similar in the respect of trying to hire analysts to help support our solutions, retain them. There is a lot of work from home or hybrid opportunities out there. So trying to keep somebody local to work in our environment is difficult. Continuing to make sure that our hardware and our software stays at peak performance, both from a storage and a performance standpoint. The cost and time and effort in keeping those up is always a challenge for us as well.
Yeah, I can imagine. And Jasmine, how about you?
it's also a challenge, as Dr. Olamu said, with increase in imaging. That also means that we have to continually increase our capacity. So we have to make sure that we're able to stay on top of the latest technology for being able to support that remote imaging. Recently, I did some numbers. We have gone from around 6 terabytes a month of saving images to now we're over 10 terabytes a month. And that's just in a year of imaging. So we have to be constantly fighting for resources to be able to support that.
Yeah, I can imagine. No, Tammy, um, we kind of started by talking a little bit about maybe challenges faced by radiologists, but how are some of these challenges affecting other radiology personnel like technologists, administrators, and the IT teams that are supporting imaging?
Yeah, so as Jasmine mentioned, of course, trying to keep up with the latest and greatest technologies is a daily battle. It's always evolving. I do know we work closely with the clinical operational areas, radiology in particular, and just trying to, for instance, making sure that our imaging queues and any of our stuck studies are moving through those processes is difficult because we don't have enough personnel either in the IT or the operational area to do those daily cleanups and maintenance to make sure that all those patient images and reports are flowing in a timely manner. So any of those areas that we are short-staffed or resources, they kind of fall to the bottom of the list and can impact patient care or the radiologist experience with our applications. So always fighting battles with resources and what's our priority to get things done.
Yeah, for sure. Jasmine, do you see that as well?
Yeah, so one of the things that we see a lot, especially with technologists, is we have a shortage of technologists, which means we have traveling techs that come in who are very green to our system. So we have to ensure that our workflows are such that they can be easily trained and they're not, as Tammy said, if they're not trained well, then they may not click the right button to get the study to the providers in a timely fashion. They might not know where to route studies. So it's a constant battle of always in a retraining mode for those traveling techs. So that puts the burden on us to make sure that we have the most straightforward, clean workflows that we can.
Yeah, I can imagine. Obviously, radiology is facing a lot of challenges, but the good thing is that radiology is very software based. It's very IT based. So there are a lot of technologies out there that could potentially enable radiologists to work more productively and more efficiently. Kyle, can you talk about some of the things that are available right now?
Yeah, absolutely. New technologies are going to have to support providers, right? Like it's evident. It's not just radiologists, it's the IT staff, it's the technologists, as everyone's mentioned here. And, there's just not going to be, we can see from CMS reimbursement for residency programs, there's not going to be enough physicians to backfill the retirement. And with the amount of increasing imaging studies because of, just the proliferation of imaging and its role to play in care, we have to develop technology in thoughtful ways so that we're not throwing technology and creating more of a problem. And one of the ways that we were primarily focusing on this is really intelligently prioritizing and moving and distributing work amongst care teams. So, when we look at like what Dr. Olamu was saying, we're hiring in geographically dispersed radiologists. So AGFA as a role has to think through how are we going to prioritize those studies. But same way with Dr. Olamu, who's reading a gamut of studies, how do we keep them proficient in a day-to-day mechanism so they're getting the right study, but grouping those studies in a way that keeps them proficient. So they're not bouncing around study type to study type, specialty to specialty. And that work list prioritization is bubbling up the studies that may be getting filtered down to the bottom so that SLAs are met, so that, we're able to understand where the radiologist is globally or geographically, so that the network infrastructure that's being built out is managed appropriately. So the study is where it needs to be so the system can work fast. And we're doing this with streaming and cloud native technologies. We're looking at the flexibility that those things can offer as well so that, from like what TJ Asman was saying, we see this across the board. The amount of data that it takes, not just because the study volume, but the studies themselves are becoming larger, the number of series, the number of images. Health systems, out of necessity, have become data center managers. And we really want to help them, alleviate some of the work burden of doing that through cloud native SaaS solutions and offshoring some of that so they can go back and support their clinical staff more appropriately. And then, we could probably touch on other topics like AI and mechanisms. But again, it's from our aspect, it's incorporating these technologies in a way that doesn't create more cognitive load, doesn't create more work effort, but really tries to take and streamline the work effort for the physician so that all of these technologies are brought together in a very intelligent way.
Yeah, that makes a lot of sense. Dr. Olomu, how important is radiologist productivity to your organization, and what kind of initiatives do you have to promote staff productivity?
Well, these days, productivity has kind of come to the top of kind of the most important aspects of a job. Before you kind of join a practice and you kind of read a few studies, you're done. Now we track productivity. When someone applies for a job, they expect to be told how much you expect to be reading, what their goals are, and you expect to be given them some feedback on how they're doing. So in our practice, productivity is one of the key things that we look at when determining someone's compensation. That's one factor, of course. The amount of shifts someone's doing also matters. So that's something that we kind of keep track of. We can keep track of that in real time. We can get quarterly updates, yearly updates, weekly updates, things of that nature. And the best way for us to kind of at least have an amount of studies or a certain batch of studies to read is to have that separate out in the work list. So each radiologist kind of has a work list made for them, so they know what studies they're reading, and then of course that leads to productivity. But for sure these days, productivity is a key factor in determining someone's compensation, and of course what they're paid per study. So that's something we do keep a close eye on.
Yeah, Tammy, from your end, how is productivity being tracked?
So we use a few different metrics. We do have some business intelligent tools that we can run data out of AGFA. We also have some out of our EMR, which is Epic. And so we can look at the volumes by modality. We can look at reading providers, productivity based on the type of studies. We also have some of the AGFA tools like the Ruby Orchestrator that we're working on implementing right now to help prioritize, as Dr. Olomu mentioned, the reading work list and making sure that the right studies go to the right work list and are prioritized. We do have multiple locations. We have 6 hospitals and several imaging centers that our practice does read for. So that is a key for our productivity, to be able to bring all those into one reading work list for our providers and not have to bounce between those. An interesting little tidbit is we did look at just the CT modality, and we looked at a 5-year span. Our CT volume was significantly increasing. And over that 5 years, we had consolidated our reading practice. We had lost a few radiologists to retirement and other opportunities. And when we looked at the throughput from order end to final read, our productivity or the throughput had stayed consistently flat, while our increased volume of CTs was significant. So I feel like all of the things, all the levers we're pulling with the different applications and the different working lists and et cetera, have definitely shown results in meeting those needs of our physicians.
Oh, that's great. But sometimes it's got to feel like you're just trying to keep your head above water, right?
Treadmill, yeah, or treading water a bit, yes.
Yeah. Kyle, what kind of tools does AGFA offer to track productivity?
Yeah, I think Tammy mentioned, there's a lot of tools that we're offering now around work list distribution and being able to measure those departmental metrics on units, staff, productivity are all things that we really try to work with our customers on. I think us internally, we also try to look at performance metrics at a quality of life of the end user's perspective, right? Like they're going to be asked to do more and more. What can we do to ensure that burden does not create such a fatigue that either their quality of life is pushing them to retirement early? What are you doing to make sure that they kind of leave work with some energy left? And also we know that, hey, a tired physician is probably not the best physician for patient care. So what can we do, not just from making sure that there's optimization in how we distribute work, but also distribute work fairly so that, physicians from case load as well as case difficulty, it's being distributed fairly. And what are we doing to ensure that we're measuring how well are hanging protocols working, how much mouse movement is going on? What are all the aspects that we really want to look at when we think about how can physicians be more productive, but also how can they not be as fatigued by reading more?
Yeah, definitely. Now, we've got all these great technologies that we can use. We've got workflow orchestration and AI is coming and all this kind of stuff. Jasmine, how difficult can it be, or how difficult is it to implement these new technologies in typical radiology department? Do you ever run into like bottlenecks?
Oh, it's a bottleneck after bottleneck. It feels like Michigan where there's always construction. You can never get through. We see all of these great things that AGFA or other vendors have for us. And then you think, okay, they're bringing this out now, but we won't have it for 2 years. First, you have to fight for budget. So you have to get on, our budget for this year is already set. So if there's something new, we won't be able to look for it for a year. And then you have to go through our architecture to make sure that we have the support and approvals. And then there's, especially with such a large health system, you have to get buy-in from all of the clinicians, because a change that one clinician might like might not work for another. We have that in our OB area right now. One person wants something new and somebody else may not. So it can be very difficult, and it's very frustrating that it takes so long to get something that could be so great for our providers.
I can imagine. Kyle, let's dive a little bit deeper into this idea of workflow orchestration and web clients that enable technology to support larger radiology groups that are maybe spread across different facilities in the system, but also maybe different geographies. Can you talk about what these technologies mean and how IT tools like intelligent work lists can help balance radiologist workloads?
I think it's, very interesting, the paradigm that we're in with radiology. The sheer workflow shortages and the amount of work to do are creating a necessity sometimes for healthcare organizations to get a little bit creative with how they're going to get the work done. And so we see oftentimes where a healthcare organization may have had all staffed physicians, and now they're moving towards reading group and outsourcing, or it may be split, or they may have a reading group that they're outsourcing reading to that can't keep up with the demand of the rising volumes that they're producing, and they're having to go out and work with multiple reading groups now. So workflow orchestration in this new paradigm is extremely important from a back-end infrastructure to make sure that studies are routed appropriately, that data flows appropriately. And from our side, we're really trying to make sure that we limit the amount of data movement that's necessary, and also make sure that study assignment is done in a way that's scalable for an organization. So the key here really for us is not just thinking about getting the right case to the right physician at the right time, but also like who is first the individual that may have privileges, especially if you're hiring outside states or you're working across state borders. These are things organizations are oftentimes now conflated with, is how do we make sure that this study is not read by accidentally and put into a work list for a physician to pick up that doesn't have privileges for that facility. So all those things have to be built into an intelligent workflow orchestration, and then making sure that essentially the practice of radiology of that workflow orchestration is native to the tools, so that communication can happen appropriately downstream between the radiologist and care provider, and having a streamlined browser environment for those things to happen with screen sharing and appropriate communication tools. I think it really gets into having a thoughtful process around how you're going to integrate that end-to-end workflow, and not just the study list distribution from QC and retakes, communication back to the technologists. All of this has to be done in a very thoughtful way, because the relationships that are, starting to be developed between the different healthcare providers within a community in a metropolitan area are definitely evolving past the simple nature that they were in the past.
Yeah.
So I think that's one thing that we're really focused on is workflow orchestration in this new paradigm, and also ensuring that the infrastructure that we're building within our system still allows the system to work fast by limiting data movement and things of that nature.
Yeah, very good. Jasmine, any thoughts on the workflow orchestration issue?
Yeah, we have a diverse health system that we support. We have critical access hospitals, rural health hospitals, and we have a level 1 trauma center. And each one of those locations requires something different. And so we have utilized our work list as we have them to be able to distribute the work according to what works best for our radiologist. And we are working with AGFA to implement the orchestrator in a way that will make that even easier than we are now. Also, the web client, we are actually getting our first out-of-state radiologist. So we're very excited to see how well the web client and streaming client will make it easier for us to support those providers that are great distance away.
Yeah. Tammy, how about you?
Yes, as Jasmine mentioned, I was going to note that we have several that are a few hours from our central hub of our hospital using and reading remotely. So we do have our first greater than out of Michigan, out of state reader. So we are excited that we do have streaming client in place to be able to provide that functionality and hopefully a seamless integration for this new provider. I think the workflow orchestrator, we're very excited about some other additional features, and the Ruby orchestrator is the official name, AI platform, but also being able to do some additional things like our night readers, being able to drive some of that workflow automated. As we've mentioned earlier, we do have shortages everywhere. So the night reading group, we have to have manual effort to route images to that group. With some of the tools that AGFA offers, we'll be able to set up some rules that when those readers are scheduled, we can drive those images and reports directly to that group instead of having manual intervention. So again, we're always looking for ways to optimize, streamline, and reduce manual effort from any of our clinicians.
We've got a few questions coming in, and we will be getting to those shortly. I'd just like to remind everybody that if you want to ask a question, please use the Q&A button at the bottom of your screen. So, Dr. Olomo, one technology that's really been getting a lot of attention in the last year or so has been radiology reporting. And, so many new solutions are coming out that look really exciting and have the potential to help radiologists improve their productivity. Can you talk about what you're doing in structured reporting and how it contributes to radiologist efficiency?
Yeah, for sure. So with interpreting images, the most important thing is to have your eyes on the images and not on your dictation software or anything else. So by having structured reports or templates, I mean, if a study is normal, you really don't have to do much but open up the study and hit sign. If a study has many complex findings, then you want to have a way to, accurately put those findings in a report, but also be efficient and being able to kind of get done with that study when it needs to be, as opposed to being stuck continuously editing a report. So there's some options that are available out there. We have not actually started using it yet. It's things like automated impressions or even report generations where you just kind of say your findings and that comes to play. Right now, we have a lot of templated reports where we can use pick lists, things like that, or have values automatically into the report instead of saying every single value. We have some software that can help us with that, so just some OB ultrasounds. So the most important things right now is to really find ways to kind of have shortcuts to having very accurate, detailed reports without spending too much time doing things like editing or organizations, things like that. Having all that available for you. For sure, the impression section is another big thing that I know is very popular with some softwares right now.
Yeah. Any particular tools that get you really excited, Dr. Olomo?
Yeah, I mean, I think the automated impressions is very exciting. I think some companies offering things like even creation of reports by you just saying what the findings are and having a report just generated by itself. Some tools are available where some prior reports can be potentially analyzed and configured into a new report with updated findings with minimal effort by the radiologist. So anything that would help the radiologist kind of save time in generating reports will lead them to be much more productive without affecting the quality of the reports.
Very good. Kyle, any thoughts on reporting from you?
Yeah, natural language processing, large language models, the whole topic of generative AI and reporting space is really exciting because obviously we've got to reduce the time it takes for a physician to get from image to report. And these tools do that. And like Dr. Olamu said, it's also the cognitive load of having to go back and forth between the text area and the image area. We've got to reduce that as much as we can. And that's one of the things that we're focused on is ensuring that all those tools are very, very tightly integrated bidirectionally, utilizing standards like Firecast and IHE profiles to where if a measurement's made in the viewing area, that measurement's automatically passed to the reporting area. So when they're dictating that finding, it's linked. And then ideally that linked measurement can be clicked on in the report and then pulled up in the series. So these two systems work very bidirectionally in the future. But we as an industry really are trying to hone in on those standards like Firecast and IHE profiles to ensure that we can build this once and leverage it regardless of what reporting vendor you want to utilize.
Very good. Now, Jasmine, you've got some familiarity with natural language processing, NLP. Can you talk a little bit about that?
Yes, we're embarking on a new journey with our EMR vendor, Epic, to start doing some natural language processing to start pulling out actionable findings for our radiologists. So right now, it's a very laborious process, I would say, for our radiologists to pull out an actionable finding and put that into Epic so that it's on a list so that it can be acted upon by our providers. Because, just because it's in the report doesn't mean that it's actionable for our providers. So we're starting on this journey. We're going to start with lung screening so that if a provider discusses, for example, a lung nodule on the CT exam, Epic will find that in using natural language processing and create those actionable findings for the end user. So it's less load on our providers. So we're very excited about helping on that avenue.
Very good. So, Jasmine, let's continue by talking a little bit about how radiology collaborates with other service lines in the healthcare enterprise. What kind of collaboration tools on the radiology side can help you partner with some of these other departments, emergency and oncology and people like that?
So with our radiologists going remote back in the beginning of COVID, one of the things we found was a big deal was providers could no longer walk down to the reading room and just get a radiologist to go over a study with them. So we've recently rolled out the collaborator. So when a provider is looking in our EMR at an image from the web link, they can click a button and collaborate with the radiologist real time. They can watch the radiologist move their mouse. They can watch the radiologist point out different things. So that gives them that real time collaboration. So we've just rolled that out with our latest upgrade that we did a couple months ago. So it's still gaining traction, but it has a lot of potential, especially as our radiologists are more remote than they were used to be. We also have the ability for our radiologists to use that same collaborator tool to talk to each other. They're no longer in the cubicle beside them. They can use collaborator to share a study and say, hey, what do you think about this? Or, hey, can you give me your opinion on this? And just share the study, have it open up in another window so it doesn't disrupt their workflow and allow them to have more collaboration. And we also are able to pull in more types of images into our single pack system. So we have our cardiology, we have our radiation therapy, so that they can see more images side by side for our other service lines in the same type of viewer. So it's more consistent for them.
Great. Very good. Dr. Olomu, AI is such a hot topic right now. And so any discussion of IT tools in radiology really has to touch on AI at least a little bit. What kind of perspective do you have on AI and radiology? And are you looking at implementing AI at the University of Michigan Sparrow?
Yes, AI is a very big topic, and I think at this point it's really almost like an assistant, a helper to radiologists and other clinicians. Some big ones out there that we're using currently. One is just with rapid AI for stroke detection. Now we send them the images pretty quickly. We get the results back whether or not there's a potential large vessel occlusion. That could mean that the patient could go for the neuro intervention quicker than I know before, where they may not have to wait for results report. Now they can see, we can see it, other clinicians see that there's a potential problem with a patient very early. Another one that's also getting traction is with breast cancer screening with mammograms. There's lots of AI tools out there now, so that's something that we're also implementing with our new breast center that we're kind of is in progress right now, under construction. But in the next 3 months, we'll have that tool where it's basically an additional eye on the images that's much more advanced than our current CAD detection, where
Yeah.
we'll see a potential finding. We'll get percentages on how risky this finding is. And that could also help our workflow, help patients get seen sooner for diagnostic studies or biopsies. There's many tools out there, tools like ADOC, where things like intracranial hemorrhages, pneumothoraces, incidental pulmonary embolisms are detected very quickly and marked. That's all helps patient care. It helps patients get seen, but and sooner, helps them get treated sooner, and it can have a very impactful, um, big impact on their outcomes. So I think that's why AI is very very popular now. For one, because of a lot of places are very short staffed, so we need an additional set of eyes really to find potential critical findings. Sooner.
Yeah. Tammy, any thoughts on AI and radiology?
Yeah, so as Jasmine mentioned, we have Epic Nebula, which we're going to be leveraging in the very near future for incidental findings, launching it with lung screening, but then hopefully following up very soon after with things like breast imaging and some other areas to catch those potential cases that need further evaluation. From a strategic aspect, we've been working closely with trying to figure out like how to get a committee together to evaluate the various AI tools, vet out the algorithms, what makes sense for our organization by, location, et cetera. I also work closely with our medical center out of Ann Arbor and our partners at West in Grand Rapids to watch and understand what AI tools they're looking at and implementing and seeing where maybe it's a good fit for our Sparrow locations as well.
Very good. Kyle, your thoughts as a radiology IT vendor, your thoughts on where AI is going right now?
Yeah, Tammy mentioned it. I think you really need to. Most organizations have to step back, take the strategic look of like, how are we going to evaluate? How are we segmenting the different AI types of tools, right? Like, are we going to look at this from a perspective of triage, brain bleeds, PEs, things of that nature, like Dr. Oluma mentioned? Is it more of an efficiency type of gain around lung nodule detection, or in neurospace doing volume measurements for uh, and also looking at, there's nice AI algorithms now around Alzheimer's, and measurements that kind of are tracking for that. And then lastly, is it a quality type of tool? Are we going to use this from a peer review, second reads, as they mentioned? Like, are we going to use large language models on critical results, things of that nature? So really trying to kind of look at these things, and how are we going to segment them out? How are we going to take a strategic approach of not only analyzing which tool and which vendor, and then how is those tools going to work in our workflow? Meaning, in this type of instance, if it's a triage tool for pulmonary embolism, how are those results going to get to our PAC system and prioritize our work lists? If a finding is stat, but the study wasn't stat, how is that going to elevate the study within inside of a triage case and activate the appropriate teams? So I think at this point, most organizations are recognizing this is not something that we can continue to just go out and kind of pick solutions off the shelf and hope they work. We really do need to take more strategic approaches of how we're going to analyze it, implement it, and continue to monitor the effects of it, not only on clinical care, but on productivity. Because effectively, we really want to make sure that all of these tools are not just throwing more information at the radiologist, but being able to be used from a performance perspective as well.
Yeah, exactly. Very good. Well, that concludes the panel discussion section of our chat. We do now have time for some questions from the audience. If you'd like to ask a question, please type it into the Q&A button down there at the bottom of your screen. And so I'm going to start with a question from Divik. What are the biggest challenges radiologists expect to get resolved with new age AI solutions? Dr. Olomo, do you want to tackle that first?
Well, I think that the biggest win would be to have improved turnaround times and results, especially critical results, faster to the ordering physician or provider. That would be the biggest win. We do not want a study, potentially an outpatient study, sitting unread for days while they've had a pulmonary embolism or even an intracranial hemorrhage, and that's unknown until a radiologist opens up the study and sees it by surprise. So that's one thing, and two is just being organized. So or having you know an a pre-analysis performed before you even open up the studies. Things like lung node detection or even aneurysm measurements, things that may take time while interpreting in real time, but if you have that already available due to an AI vendor, AI solution, then that'll be another big win. So I think, and then of course with the screening mammograms, that detection, that's to improve your detection rate is always a big win. And there's been studies on that where, using the radiologist plus an AI solution can improve cancer detection rate. Of course, that's very good for the patient and for the practice.
Yeah. Any other thoughts from the panel on the issue of AI adoption there?
From a HITS perspective, for us, strategically, again, we have partnered with AGFA with the Rupee solution just to try to give us that platform. So as they adopt some AI tools, that we can involve those into our AGFA solution as quickly as we have the appetite to do that. So trying from a HITS perspective to think strategically of what partner we want to work with just for that platform as those AI tools become available makes it easier than just going out and kind of shopping for things one-off as they come out.
Yeah, Kyle?
Yeah, I think again, it's like separating the what are the challenges again from a how do we improve patient care to what Dr. Alamu said from a finding things that weren't there or finding things that we didn't have time because it's too far down the study list and filtering it so patient care is improved. Efficiency gains, and that could be from image like we discussed, image interpretation AI, but also in generative AI and the reporting side, like what efficiency gains there. And even on generative AI, we see things from like partners like we have with Rad AI and others where they're looking and finding laterality or sex, like it may have misinterpreted, the VR may have misinterpreted something and there may be a discrepancy there that it can kind of uncover. So I think that those are really the two things I see from a radiologist perspective. The other aspect that maybe I'll go beyond the question from a radiologist perspective. What we're really excited about with our cloud and our partners like AWS is utilizing AI and the infrastructure adoption and how are we going to manage infrastructure appropriately. There's a lot of very interesting AI mechanisms that we're starting to adopt and be able to leverage to make sure that the system itself is operating at tip-top shape for the radiologist. And sometimes it's like the unsung heroes, if you will, like Tammy and Jasmine. It's like those people operating behind the scenes that really allow the clinical team to operate at the top of their license.
Yeah, for sure. So we have a question from Mike Canavo. Have you noticed a difference in adoption of changes in PACS and acceptance of AI between younger radiologists and older radiologists? Dr. Olumo, you want to tackle that one?
The short answer is yes.
Okay.
Well,
Let me guess. The younger ones are the ones that are more enthusiastic about it.
You might be right about that, but I think, if it's presented to you on a platter, like this is the AI findings, this is what it is, it's in front of your face, you have to do nothing other than digest it and report it, or it's in your dictation software now, this is what it looks like. And if it's like that, presented in a way where it's an easy to use solution, it will be adopted very quickly. And I think these vendors are now learning that. So a lot of the things that I see are pretty straightforward and easy to learn. And I think it's adopted by all Ken radiologists. But again, if it's a tricky thing or if you have to open up a different software, push many buttons, then that might not be accepted as easily.
Yeah, it's all about implementation, right?
Yeah.
How easy. Any other thoughts on that, the youngster versus oldster divide? So we got a question from Shabir on mammography. With the increase in 3D tomosynthesis versus standard 2D mammography and the significantly larger data sets and the time needed to review the many images versus basically 4 images with traditional mammography. How does this impact workflow and reader fatigue?
Yeah, it's definitely affected reader fatigue. When I started, it was almost half and half, 2D, 3D for screening mammograms. Now the goal is basically 100% of screening mammograms are 3D with the tomosynthesis. You get multiple slices. Some studies have hundreds of images. So again, if you're looking at that over and over again over hours, there could be some fatigue. There could be some risk of potentially missing up a finding. So that's where you know tools like CAD, which is used to be good, not as much, but now AI, that kind of takes us to the next level where, if that's always around, at least we have that second set of eyes, so to speak, to help protect us. But the volumes are always increasing, not decreasing. We kind of have to adapt to it. I think also having a very responsive and efficient PACS is good, where you're not waiting too long for these very large studies to load. If you can open up a study and the images are there right away, it's smooth. I think that also helps, the having to deal with lags and glitches adds to fatigue, I would say. Having a very smooth, functional system can actually, and you gain some traction, can actually be pretty good for productivity and decrease fatigue.
Yeah. Tammy, you mentioned earlier that your data storage requirements have gone up so much into, I don't remember the number, but it was just multiple terabytes. How much of that do you think is DBT contributing?
It is a fair amount. We have had a increase in the volume of our CT studies overall comparison to other hospitals as well. But a lot of them are the breast tomosynthesis that are increasing. And as Dr. Olamu mentioned, that has been Jasmine and myself and our HITS team. One of our priorities is trying to make sure that whether you're physically at our campus or remote reading, that the speed of those images loading and any glitches are pretty much eradicated the best we can, because we do know that it can impact not only physicians' preference and comfort level, but just in overall reading the study and not making mistakes if there's delays in loading. But yes, most of them are from the 3D imaging.
Yeah. Kyle, as a vendor that's developing this software to manage these images and store and things like that, I mean, is that how much does the increasing volume or the size of these studies, how much pressure does that put on you guys?
Well, I mean, we have enough pressure that we don't need other things to put additional pressure on us. However, I will say it's something that we consider and have considered now for several years on how we do a well architected backend. So as Tammy and Dr. Olamu said, this is broad based. This mammography is one huge component of it. Large file sets for DBT, fusion, other aspects are all components of what we have to take into consideration in the new paradigm of readers being anywhere at any given time. And not only the reader needing to be able to have access to those images, but how are they going to communicate? Can like they were mentioned prior, a screen sharing session be loaded, and how is that going to affect in a case where it is a DBT? So we've architected our solution with the streaming client to not have to move the study to the physical location of the radiologist. All we are moving is the pixel data in transit. This greatly reduces not only the load on the system, but it also ensures that ad hoc access to studies are readily available, meaning I can make this happen fairly easy by just pushing a ton of DICOM data or JPEG 2000 data to a workstation. Any vendor can do that. Our approach is that's great, but if all of a sudden I need to pull up a study that I did not have on my work list, that workflow breaks very quickly. So with streaming technology, we've ensured that regardless of what workflow they're in and where they're at, we can give ready access with speed to full fidelity images.
Very good. So we have another, doubling back to AI, another question from Mike. How are you presenting AI to the C-suite so it can be accepted and they'll sign off on the purchase order to buy it? There needs to be some sort of return on investment, whether it's productivity gains for radiologists and technologists or others. improve patient care is great, but someone needs to pay for it until CMS and insurers include AI in the cost of an imaging study. Dr. Olomu, what is the best way if you want to get an AI application adopted? What's the best way to kind of present that to administration?
Yeah, for sure. There's got to be something that you get in return. So for breast imaging, it's increased accuracy. For the stroke imaging, rapid AI, it's quicker detection of significant findings, whether it's intracranial hemorrhage or large vessel occlusion. Now, with that solution, actually, I think there's actually some ways to get some reimbursement on the technical side or to the hospital when some of those solutions are used. So that part where you're actually getting paid to use that solution is, of course, very attractive to the hospital. But a lot of other solutions do not really come specifically with added revenue to the hospital. So definitely it has to be based on the fact that you're using the solution to help the patient, and you might help productivity. I think those are the most important selling points, but those are always obviously pretty hard selling points if the hospital is going on a deficit or is losing
Sure.
revenues because of that.
Yeah, and another thing that comes to mind, Dr. Olomu, kind of harkens back to what you said earlier about using AI for stroke, which is if you can detect a stroke earlier and not have that patient languish for a day or two, that's going to reduce your malpractice risk. And I'm not a hospital administrator, but it seems like they're very risk averse. So that is something that could be used as a selling point. Any other thoughts on how to pitch AI to administration to maybe get them to sign off on an acquisition of software?
I was just going to say, to piggyback on that thought you just had, not only does it reduce malpractice insurance, but it also reduces the amount of intervention that may be needed. If you find a breast cancer early, they need less treatment or less extensive treatment. If you find a stroke early, they may need less extensive treatment, less length of stay. So that really does help improve the care and reduce the cost of their care.
Yeah, Tammy?
Yeah, Jasmine, actually, I was going down the same path. So rapid, for instance, it does help us identify if there is brain matter that is salvageable. So if we can get them to a coil, balloon, stent type of procedure faster, they can recover more of that brain material or brain matter, which dovetails exactly what Jasmine was saying in reducing length of stay and maybe long-term care support because of the impact of a stroke. So I think really delving in and understanding what the AI tools offer and being able to parse out those specific details of how it could improve patient care, reduce length of stay. All of those things are definitely items that we try to call out as we're subjecting our AI requests up through for budgeting.
Yeah, for sure. Time is brain, as they say. Well, I'd like to thank everybody for your questions. Unfortunately, we're not going to get a chance to get to them all. But I want to give everybody a chance to give our audience maybe a couple words of advice for how to proceed with implementing IT tools. Jasmine, do you think you could go first and maybe give our audience a couple things that maybe you've learned in working with IT technology for radiology and improving productivity?
I think one of the biggest things that I've learned is trying to make sure that you are keeping the radiologist in one, maximum two software programs. You want to reduce their having to open, log in, sign in. You want to keep them close, which means making sure that other softwares that you're trying to integrate have tight integration couplings, have APIs, have Firecast, and you are able to work them into a seamless workflow. I think that's the most important thing.
Yeah, for sure. Workflow is so important. Tammy, teammate, how about you? Any words of advice for our audience?
Yeah, so mine ends up being more of a strategic standpoint of trying to identify how we can make that work, to what Jasmine mentioned. So some of the ways we've been able to leverage that are the way we set up our maintenance agreements and factoring in future technologies so we don't have to go back to the budgets and get additional funding. Also trying to stay, we really try to ask why not? Why not AGFA? Why not our Epic? When we start hearing about these other third-party solutions. So I think that's really helped us not only with what Jasmine said, but from cost and implementation standpoint of if we can't do that with one of our big vendors that we already have in place, then really we'll go to a third party. But if we can, we try to stay and use a tool that we already have in place.
Yeah, it makes sense. Dr. Olomu, any words of advice for our audience out there?
Yeah, I think the most important thing is just being competitive, especially when you're in a health system that has a lot of adjacent health systems which are competing with you. So you to be a very successful practice, you want to have, high-end PACS solution. You want to have AI tools available because you know your competitors well. You want to keep the radiologists basically in a very productive, efficient setup where their PACS is good, the voice recognition software is good, you have good EMRs. All the solutions are available. As Jasmine said, we do like to have one enterprise imaging, one software, one solution where we can look at the images for the CT, X-ray, mammogram, PET CT. All that is in one program. That's very, very good for us, and of course, it's very fast. So I think staying competitive in a market will attract more candidates. A new candidate would want to know that your practice is doing what it takes, to be always, at the top of the field when it comes to having the right technologies in place.
Yeah, very good. Kyle, some words of wisdom to leave our audience with.
Well, if you're looking for words of wisdom, I'm not sure.
No pressure.
But I think the biggest thing, first and foremost, thank you for having us, and thank you to the Sparrow team for joining. That in and of itself, I think, is my advice: is work collaboratively. You have to align on goals, and you have to work together for the future. You can't solve yesterday's problems today. You need to solve tomorrow's problems today. And we do that really well, I think, with Sparrow. I think it shows in the success they've had is they work with us. They bring us their problems. We align on strategies, and that's what it takes, right? Like, we've got to work together. And Dr. Olomu helps us guide us on how ways we can improve, right? So we're constantly involved with our customers. And I think vendors, providers, they have to work together. So I think it works really well with Sparrow. They come to us early and often, and we come to them with where we're headed. And that way we can get ahead of the curve on things. And like they mentioned, work with your vendor to make sure, let's not overspend or overcomplicate things. If we can do something with someone, and if they can't, let's say, hey, this is the route we're going. Can you guys make sure that you're going to be able to integrate this in the way we want? So that collaborative nature and working together is really what's necessary for a health system to be able to deliver the care and be competitive, like Dr. Olomu said, in their region.
Yeah, and Tammy and Jasmine, you're going to be appearing at a conference coming up soon where people can kind of learn from you in person. Can you give a few more details on that?
Yeah, Brian, thank you for reminding me. We will be at the AGFA user group. I meant to say that in September. So Dr. Olomu, Jasmine, and I have been asked to present there again. We've been there in the past. So that has been a great format to connect with other systems that are using AGFA, kind of learn from them. And of course, we have direct contact with several people from the AGFA vendor, solution engineers, sales, etc. So we can bend their ear quite a bit at that. So it is September 15th through the 17th, if I have the dates correct, in Florida. So I believe it's our third or fourth year, and every year it gets better speakers, more information, more networking, great experience.
Great, good. Well, I'm sure that you'll be hearing from if you're an AGFA user, you'll be hearing from them about that, and definitely, talking to other users is, as Kyle mentioned, the best way to kind of sort through some of these issues. Well, I'd like to thank everybody in the audience for joining us. Thanks so much. Really appreciate your support. I'd like to thank Jasmine Holloway, Tammy Skoke, and Dr. Osa Olomu of the University of Michigan Sparrow, and Kyle Salini of AGFA HealthCare. Everybody, it was a great discussion day. Thanks so much for being with us.
Thanks for having me.
Thank you for having us.
All right. Once again, thanks to our audience out there. Signing off for the Imaging Wire, my name is Brian Casey.